The Veteran Lived Experience series features personal conversations with veterans who have agreed to share their story on topics prevalent in the veteran community. Veterans are joined in discussion by professional experts and members of the Veterans Health and Wellness Foundation team.
Good afternoon, everyone, and welcome to the Veterans Health and Wellness Foundation Veterans Lived Experience Series event. This is brought to you by the foundation typically once every other month on Tuesday at 1 p.m. My name is Dr. Evelyn Lewis, and I'm your host, and I serve as president and chair of the foundation. The foundation itself is a nonprofit 501c3 charitable entity. It was established by military veterans with expertise in the areas of health, wellness, healthcare delivery, and where those intersect with the social determinants of health and military culture. What we do is embodied in our mission, which is to build, educate, and maintain source networks to support and complex physical, social, and emotional needs of veterans and their communities across our nation. Our vision seeks to expand communities that possess the knowledge and capacity not only to identify and address some of these service-related health challenges, but also to embrace, support, and empower the veterans and their families who experience them. So bottom line up top, for veterans and their families to be their best selves, the foundation strives to expand opportunities for them to live healthy and well lives, undiminished by their service-related health concerns. Today's topic is Parkinson's disease, and we'll be talking about that and the impact it has on our veterans. Generally speaking, Parkinson's disease is a progressive neurological movement disorder that deteriorates over time. It's characterized by weakening, damage, or death of nerve cells and neurons in specific parts of the brain. This can lead to various movement-related issues such as tremors, stiffness in the limbs or trunk, and impaired balance. As the disease progresses, many may experience challenges with walking, talking, or performing routine daily activities. While there is no cure, medications or surgery can often provide substantial improvement with some of the motor symptoms that are experienced. The disease has four primary symptoms. Tremor is one, and probably most people are familiar with that. It's a characteristic sort of shaking, rhythmic back and forth motion that involves the finger and forefinger. And most of the times it's referred to sort of as a pill rolling motion. Often begins in the hand and is sometimes a foot or the jaw that is affected first. There's also rigidity or muscle stiffening or resistance to movement that affects most people with Parkinson's. The rigidity becomes obvious when another person tries to move that individual's arm, which may move only in sort of short, jerky movements. And that's sometimes referred to as cogwheel rigidity. And then there's bradykinesia. This is a slowing down of the spontaneous or automatic movement, which can make simple tasks take longer and be more difficult. They oftentimes also are called or described as having a masked face because of the decrease in facial expressions. And then there's postural instability. Impaired balance and challenges in posture can increase the risk of falls. And so while there's much, much more to this disease, my guest today will help us better understand its impact from someone who has it and from someone who spends a lot of time trying to help those who are suffering from Parkinson's by doing research and other types of tasks that will lead to better treatment for these patients who suffer from this disease. So my guests today are Mr. Jerry Feldman and Dr. Hackney. Mr. Feldman is an Army infantry veteran who enlisted in 1976 at the age of 19. He completed basic training at Fort Dix, New Jersey, and AIT at Fort Benning, Georgia. He was stationed in Hawaii and later transferred to Fort Lewis, Washington, where he was honorably discharged with a 50% service-connected disability. In 2014, he was diagnosed with Parkinson's disease, which is unrelated to his military service. His professional career in marketing spans about 4 decades. He opted for early retirement at age 62, and since then, his focus has been on Parkinson's disease advocacy, clinical research, and volunteering at the Parkinson's Foundation. Currently, he is a volunteer ambassador for the Parkinson's Foundation and advisor to the VA Center for Visual and Neurocognitive Rehabilitation. He's also the proud father of 2 sons and 3 grandchildren. Dr. Madeline Hackney is an associate professor of medicine at Emory University School of Medicine, Department of Medicine, Division of Geriatrics, Gerontology, and a research health scientist at the Atlanta VA Center for Visual and Neurocognitive Rehabilitation. Dr. Hackney works to optimize physical rehabilitative strategies in terms of movement patterns and timing, dosage, duration, intensity, and the role of the partner to enhance balance, mobility, and quality of life for older adults and veterans with these movement disorders. She has received funding from the Department of Veterans Affairs, the NIH, the National Science Foundation, the Patient-Centered Outcomes Research Institute, and the Parkinson's Foundation, in addition to CDC. Now I'm going to turn things over to Mr. Feldman and then to Dr. Hackney to share with you more about themselves and their experiences, and then we'll dive a little bit deeper into the conversation with some questions for both of our guests. So Mr. Feldman, if you just share a little bit with everyone about your journey to the diagnosis of Parkinson's disease, and then we will go from there.
Thank you, Dr. Lewis, and thanks everyone for dialing in. So my journey began about 10 years ago when I was diagnosed, and my Parkinson's is not related to my service. I know many veterans who have this problem, and it is related to their service. But for me, I came back from the private sector back into the VA system to take advantage of a lot of benefits which I had not utilized when I was working. So after I left the service, I went into the private sector, and I pretty much left those benefits on the table as far as collecting disability and so forth at that time in my life when I was younger. But when I was diagnosed, that's the time I met Dr. Hackney through a adapted tango class, which I'm sure she's going to talk more about. But that began a lot of great things for me, including a return to the VA system to reobtain the benefits that I was still able to get. So after 40 plus years of being in the civilian world, I went back to the VA and I said, "Hey, remember me? I'm the guy you gave a service-connected disability to, 40 years ago," and they reinstated my benefits and validated my service-connected disability, and I was able to get 100% of my care taken care of, which was, as it turned out to be, very valuable in more than just monetary ways, because it's led me to be on this call today. But once I was diagnosed back in 2014, well, I guess some of the symptoms that I was dealing with were a left side only tremor, and that was the trigger for me that something wasn't right. My handwriting got awful, and I had a tremor that I wasn't able to control, and then the horrible day came. It all came to in one day when I had your classic panic attack upon awakening, and wasn't able to go to work that day. I had to be outside. It was very claustrophobic, uncomfortable feeling. It's like my whole world was off kilter. And I, sort of ran to the doctor's office that day saying, "Hey, what's wrong with me? What's going on?" And they quickly determined that it was Parkinson's. So that's a little bit of my background. I'm not sure how much more detailed you want me to get at this juncture.
Well, I think that's a good start for folks to get a feel for how you got to where you are. And we'll come back though with some additional questions that I'm sure will fill in additional information for people. But right now, Dr. Hackney, if you could talk just a little bit about kind of who you are, your work in the field, and in particular, perhaps that class that Jerry referred to. It seems as though that was a good sort of high point for him in terms of meeting you and in that particular class and what it did for him and his condition.
Thanks, sure, I'd be very happy to. So I'm, as you already said, I'm a working clinical researcher in Parkinson's disease, and I was a professional dancer for many years prior to being a researcher and a scientist. And so I had this dance training and I had this dance background, and I used to perform in shows, and I did ballroom dancing, and I taught a lot, and I performed and competed in all of this. And it was always this social dance thing. And so when I got into graduate school and I wanted to be a kinesiologist, that's what I originally trained to be, I was invited to go ahead and try to work with people with Parkinson's disease and could develop an adapted tango program for them, an adapted Argentine tango dance program for them. So I already knew how to teach Argentine tango to like sort of a regular community. But I had to develop ways to specifically make it very safe and effective for the motor and cognitive and psychosocial issues that people with Parkinson's face. And so Jerry met me when I was probably, I think, almost 10 years into the program. So I had made some, changes to it and iterations, but we have a lot of research and published research that shows that it was very effective for people with Parkinson's. If they went through 20 dance lessons, if they had about 20 hours of training, it was very effective at improving balance and walking ability and being able to think and do at the same time, and all sorts of things that are really important to our functional activities of daily life. And so that's what I've been doing since 2006 or so, trying to refine that program, make it better and better, and fortunately meeting wonderful people like Jerry along the way.
Well, thank you. I have one quick sort of follow-on question about that. With the success of the program that you have sort of refined, is it available anyplace else? Has it, spread across VAs or to
I
different
would
states?
love to get it spread across the nation at all of our VAs, possibly as a alternative to GeroFit, or in conjunction with GeroFit, which is the senior exercise program, which all the seniors should ask their GP or their PCP over at VA. Say, hey, I would love a referral to a GeroFit program if you're, if you're there. We have one here in Atlanta, and it's a wonderful exercise program. It's remote, and I think they're starting to do in-person classes as well. But yeah, I would love tango to be something that was offered in a similar fashion. Currently, it's not. I have trained well over 100 instructors in how to do these classes. And so I'm sort of aware of various, I know Argentine tango is offered in various communities, and people recognize that it is appropriate for people with Parkinson's, but whether my exact program is being duplicated in various areas, I would love to make that happen.
Thank you. Thank you.
We're still in research stages too.
Okay. All right. Well, we'll have to continue to follow that then. Question for you, Mr. Feldman. After your diagnosis of Parkinson's disease, what was your reaction to that, particularly after it had sunk in? What were your thoughts about how you were going to move forward?
Well, the key words are move forward, because that's the only direction you can go in, really. And the biggest thing for me was to get educated. I needed to find out everything I could about what this disease is and what to expect and what the treatments are. And it was a very difficult time to come to grips with the fact that I, had something that is a degenerative disease that is likely to get worse over time. Fortunately for me, I've had little to no progression in the 10 years that I've had it. And my my symptoms are limited to just one side only. So unlike a lot of other people who have much greater severity and much more limited capacity than myself, I feel pretty fortunate to have what I have. So it was a period of educating, self-knowledge, and reaching out to find resources. I went immediately got involved in the Parkinson's Foundation and community things. So I go to support groups. I had to read lots of material. I encourage everyone to be their own advocate because everyone's is unique and different when it comes to Parkinson's. You if you've seen one person with Parkinson's, you've seen one person with Parkinson's. It's an A to Z kind of a disease, and from that point of view, it's a horrible disease because it affects so many things, things that you can see from a motor standpoint, but also things that you can't see. Your mood, your appetite, your speech, your swallowing. I mean, your balance, your gait. There's just a lot to it. So I had to really get a handle on it and go through a period to get to acceptance. So for me, it was about not being hopeless, and I'm a very positive, hopeful individual. And my philosophy is go with what you got. If you have to keep moving, and so you have to take care of yourself. And there's three key areas I would say. One is medication management, exercise, and okay, what's the other one I'm forgetting? Diet. What you eat. So your diet, your exercise, your medicine. Those are the important things in managing Parkinson's. It is not a death sentence. It can be managed. People do live with it. So I had to go through all that, and now I'm pretty positive. I'm okay with everything, and that's what I want to. That's big part of why I'm here on this call, to convey that to others.
Well, thank you. You mentioned when you first got the diagnosis, what concerned you most was learning everything that you could about it, becoming informed, et cetera. What was there anything else that sort of shook you, if you will, aside
Fear.
from wanting to learn everything about it?
Yeah, it scared the hell out of me. I mean,
Mhm.
I heard, I saw horrible things in people, and I was very, very uh, afraid of what was happening to me. So the fear factor is huge. But what motivated me was to not be one of the people that was depressed or hopeless. That I'm not going to be that person. I'm gonna fight this. I'm gonna do everything I can to take care of myself the best way I can. I live alone, so I had no choice. And reaching out to get support and help is also critical, to not isolate and to push yourself, as I did, to get out there and get the help you need. But the answer to your question is, the thing that concerned me the most was getting worse over time, and not being able to take care of myself, and losing my ability to be an independent, autonomous person. None of that's happened. None of those fears have come to be. So that gives me greater confidence and faith, and that's why I can have a smile on my face.
Oh, good, good. Dr. Hackney, a question for you. Jerry mentioned fear. First he talked about wanting to get educated about everything, et cetera, sort of following a logical kind of pathway. But then when I kind of reiterated that question, he talked about this fear that hit him once he heard that. In your time with patients and across the time that you've spent with patients with this disease, What have you seen in terms of when they get that diagnosis? Is it more fear, anger? Are they concerned about how they're going to manage their lives? Those kinds of things. What have you seen across the span of patients that you've worked with?
So I think, it's patient specific, and different people are going to take things in a different way.
Mhm.
One thing, Parkinson's is not like a super diagnosis, right? But a lot of people have been dealing, if they have come to your office to be diagnosed, they've been dealing with these symptoms probably for quite some time. And there's a lot of confusion about it. There's a lot of, wondering if it's not Parkinson's, is it something else? And sometimes, not hearing about Parkinson's can be, in a way, a better condition to hear about, or a diagnosis, than some others. So the good thing about Parkinson's is, at least, it's pretty treatable. It is a manageable disease by and large. There are very good medications that one can prescribe. There's education you can get. There's exercise. There's a lot of things that you can do to make your experience with Parkinson's as best as it can be. Because there's other things that are much more like, pretty dire as far as diagnoses go. So yeah, I think folks are going to have to work through that. They're going to have to figure out how they're going to manage their lives so that they can have the best outcome possible. And that might mean some shifts in what they're doing and what they're eating, and some other things. The good news is it is manageable for most cases, and there are options.
What are some of the problems that someone with a diagnosis might encounter? Jerry mentioned that he lived alone, and that was, one of the things that he feared was it's kind of losing that ability, that independence, if you will. So what are some of the other problems or issues that may face, or patients with Parkinson's may face?
Besides, like, living alone in particular?
Yeah, with some of the symptoms that accompany Parkinson's, what are some of the other problems that they might encounter?
So some people experience a range of autonomic issues. They experience maybe sleep issues, maybe some cognitive issues. The thing that I focus on mostly, because I'm a movement scientist, is their motor issues. So, just being able to button up a shirt could be difficult. Writing could be difficult. If you have a lot of tremor, possibly feeding oneself could be difficult. Some people, unfortunately, with Parkinson's, unfortunately, some of them do develop swallowing problems, and those are very, very serious. There's a very serious nature. But if you have, if you have managed symptoms, you probably can have a very good quality of life for quite a long time. It just depends on the patient. If you see one case of Parkinson's, you're seeing one case of Parkinson's. And I think Jerry kind of talked about that, seeing what other people are going through. Someone else's path is not necessarily your path. Your path is your own path. But there's a range of things that people do have trouble with. It can be all the daily activities that we do, bathing, dressing, etc. Some of these things can be more challenging, but fortunately we have a lot of strategies also for dealing with those sorts of things. If you can't tie your shoes, get some Velcro shoes. There's all sorts of things you can try to do. A lot of the stuff with Parkinson's, Parkinson's is not necessarily the disease of an older adult population exclusively, because there are a number of younger people who get diagnosed, in their 40s or even in their 30s, and a fair number who get diagnosed in their 50s. But it is much more common to be diagnosed, in someone's like 7th decade, in their 60s and their 70s. And so similar to some of the things that our senior population goes through, a lot of those things are sort of exacerbated in a person with Parkinson's. So it's very related to being, aging in general as well. And so everything that comes with that, people with Parkinson's just have a little bit of extra dose of it.
Thank you. So Jerry, another question for you. You mentioned earlier that you lived alone, and that was one of the things that sort of stoked a little bit of the fear that you were feeling when you got that diagnosis. Um, while you may live alone, has Parkinson's sort of interfered in any way with your relationships with others, whether it be your sons or grandchildren or any other personal relationships?
It really hasn't, and that was part of my fear was acceptance, and it's embarrassing to be out socially when you're shaking. Like I don't want people to see me that way. So it's about self-perception and how I present myself. I like to be pretty buttoned up kind of guy, and Parkinson's doesn't really allow that. Parkinson's is going to, forget your ego, and you will learn a lot about humility. And for me, it's always a struggle to be out in public and to be doing things that everyone else is doing when I'm having a tremor, or I'm uncomfortable. I'm not at ease, and that's probably the hardest part for me. And if that's the hardest part, I feel pretty lucky, because the people closest to me, my friends and family, are very understanding, very supportive, very loving, and they will try to ease any if I'm whatever I think about myself, they'll try to help me to feel good about myself, regardless of my condition. My is my grandkids, they might try to hold my hand from shaking, and and uh and I have to say things like, your grandpa's, I'm not shaking because I'm cold. I'm shaking because I'm old. I'll try to make light of it and keep it, you know,
Mhm.
keep my sense of humor about it, because I'm not a person who's going to go woe's me and get all depressed. And that's a big problem though for a lot of people, is to not be able to do that. And I think that's why it's so important to not be alone and isolated, but you almost have to force yourself to be in situations that are not going to be comfortable, um, and work through that. I think that's part of this self-care and managing the disease.
Okay. In regard to managing the disease, as you just mentioned, what was your medical care like initially, when you first got the diagnosis, and sort of during that time of readjustment or transitioning from, not having Parkinson's to now having that disease? What has your medical care been like then and now?
That that has been the most difficult part of the diagnosis and the transition into the beginning of the journey with the disease. And it took me a good couple of years to get to a place of where my medicine was. I had the right combination of medicines. It was a process. What was going to work best for me? It's experimental. When I tried a drug that was, well, I didn't. The doctor did. The first neurologist to diagnose me. We tried inhibitors, a class of drug, and it didn't go well for me. I needed a different type of medicine, which turned out to be an agonist, a dopamine agonist. And I'm going to let you all talk about the technical meaning of what I'm describing. But and you have to find the medication and the right dosage that's helpful. And so that was a difficult period for me, because I wasn't sleeping well, I wasn't eating well, my tremor was not under control, and it was a very difficult time. But once I went on to carbidopa levodopa, which didn't happen till 2 years in other words, my diagnosis was 2014. My care at Emory began in 2016, and I was immediately prescribed carbidopa levodopa, which it was a whole new world. Everything was wonderful again, and the tremor was gone or controlled by the medicine, and so that started off a lot of good things for me. And since that time, it's kind of been that way since, where I'm managing my medicine and continuing to exercise and try to eat well and make sure I'm connected and have support people like you all. And that's so the hard part is getting to the place where your treatment is working.
And Dr. Hackney, in regard to the treatment, in particular, different types of medications, can you tell us a little bit about the different classes of medication, and perhaps if there's any kind of typical person or type that it works better in? As Jerry mentioned, he started with one medication and it didn't work as well until he got to levodopa, and now he's sort of in a steady state with that. Can you tell us a little bit about the various medications that are out there, and somewhat how they work on the different types or stages of Parkinson's that that patients have?
Sure, I'll just talk in a very general sense.
Mhm.
So there's medicines that are not strict levodopa. They are precursors. So you'll take them first before you actually move up to taking actual levodopa, which is the dopamine replacement therapy. So before the doctors put you on the dopamine replacement therapy, they want to put you on something that will kind of, I don't know, take care of the remaining, remaining dopamine that you already have, and will help your symptoms in various ways. And that's probably something what Jerry was talking about, that the sort of like precursor kind of medications that folks often go on before. The reason you don't want to go right away on levodopa is because it's it's a very powerful drug, and it can have side effects down the road, and it can have like these wearing off effects. So like, for example, if you might see some people have what we call dyskinesia, it's like there might be like extra little movements here and there. That's not from the condition or the disease itself, that's from the medication. And so the doctors want to delay that beginning the levodopa until, they really need it, I guess. But once you're on it, levodopa, like I said, is very, very strong medication, and it's very effective. And a lot of people get a lot of relief from that. After that, it's a condition, it's a process. That's what Parkinson's is. And your brain is changing all the time, and the levels of neurotransmitters are changing, and the network, the way your neurons communicate with each other, are changing all the time because of the progression of the disease. Therefore, you're going to have to change your medications over time so that they work better for where your brain is at that stage. And so it's a constant like discussion. And I think most people see their neurologist maybe twice a year. They see him every 6 months or so. And you have to really talk to your doctor and try to get the right combination of anti-Parkinsonian medications so that you'll get the best relief. Sometimes people also will discuss deep brain stimulation at some point. Some doctors think you should get a deep brain stimulation as soon as possible, and others think you should delay it for as long as possible, and delay it until like the medications aren't working so well. And some of these medication related motor fluctuations or off time or dyskinesias have started to emerge. They think you should wait until then. So there's like debate even within our, movement disorder specialists about when you should do this or that. And again, it really comes down to a lot of conversations with your care team, which should include also physical therapists and speech therapists and every other, the allied health professions as well, whatever you need so that you can arrive at the best form of care. But there are a lot of options out there. The one thing that is the gold standard typically is our levodopa, which was developed several decades ago. But they're getting better with like how it's administered. I think there's like a patch you can wear. I think there's like There's a spinal thing where it gets administered into the spine. There's like different ways that one can get these medications, and it's important to try it out and figure out what works best, but also recognize that as you change, that you may have to change your medications and your approach to your Parkinson's as well. One thing I would say that needs to be a constant: stay active, get lots of exercise, do it as much as you can. Try to be socially active. That's really good for the health as well. It's very important to attend to your mood and keep your spirits up and look for ways to deal with each little symptom as it comes. I think sometimes people try to take everything on all at once and they want one magic pill that will just fix it all. It's kind of not that way. You got to take one symptom at a time and try to address it.
Thank you. Another question around the progression of the disease and how that, relates to treatment. And what I'm talking about is, you mentioned earlier that it's typically a disease of folks who are in their 60s and 70s. However, people in their 40s can also develop Parkinson's. And so what do we see with the progression of the disease in the people where it occurs much earlier onset? Is the treatment any different? Do they manifest any other significant symptoms? What does it look like, for them when they get 60, if they develop Parkinson's when they were 40?
So again, it just depends on the case, right? So it could be various things. I think that, diagnosing Parkinson's is actually very difficult. It takes a lot of expertise. That's why you should really go to a movement disorder specialist to get that diagnosis. Those who are younger, they have the benefit of being younger. So therefore they may have, a terrible tremor, but they can still jump 6 feet if I ask them to do the broad jump. So I have worked with younger people, and they, had some really challenging, symptoms, certainly with the hand, the ability to move the hands, and maybe they had a terrible tremor or this or that, but they still, still had good balance function and some other things. But it really depends on the case. Like I said, it is difficult to know sometimes that it's Parkinson's for sure and not something else. A lot of times those who have what we call young onset, that means they might have more of a genetic relationship to Parkinson's as opposed to idiopathic Parkinson's, which is like without known cause, which is what we see in our older adult population a lot more. So anyway, they have the benefit of that youth, which is it's helpful in a way. But they might have, again, it's the constellation of the different types of symptoms that it could be that can affect you when you have Parkinson's. And I'm not sure that there's specifically that what I've seen anyway is that those with young onset have something in particular. The 4 cardinal signs of Parkinson's, the way you get the diagnosis, are postural instability, rigidity, bradykinesia, and tremor. And you have to have 3 of the 4. And some people would say you have to have 2 of the 3, and they don't include postural instability. Bradykinesia means slowness or poverty of movement. So Parkinson's is a hypokinetic, absence of movement kind of condition. It is not a hyperkinetic condition. And so that's where that slowness or poverty of movement. But what I see a lot of people get diagnosed from is just that tremor that starts. And again, I really, really recommend people go to a movement disorders trained specialist neurologist to get your diagnosis, because they'll have the best information and be able to do a really thorough workup and make sure you have Parkinson's and not something else.
Yeah. And Jerry, as you've talked about your experience with Parkinson's disease and how you have approached it, you've been a very positive and very hopeful person. You've had a very good support system around you, but for many that is not the case. They don't have a strong support system, and they still may be living alone and sort of somewhat in isolation. So what would you say to others who are facing a life with a diagnosis of Parkinson's, who may not be sort of in the same environment or space where you have been with your diagnosis?
I would encourage them to not be alone and to reach out and to help, let others help you. In other words, you can't take this on by yourself. You've got to have almost a team of people, the doctors and therapists, or whatever the things are that you need to seek care for. Get the care you need. Don't stay home and hide in bed. Don't. That's not the answer. You've got to push yourself. You've got to get yourself, find ways to get the help that you need, because it's not something that is going to get any better or fix itself. And so the biggest thing is to take ownership and step up to the plate to help yourself. Um, be, and that's what I would encourage people to do.
And one of the places that at least I've heard from you where they can find some of um, these
Well,
resources and support. You
I,
mentioned
as I said initially, I went from my general neurologist over to Emory because at that time I was still working, and my insurance was taking care of things. And Emory is a center of excellence. They have a comprehensive care clinic. They have a dedicated brain health center. They have an excellent staff of experts and movement specialists and resources that are incredible. So you couldn't, if you're going to have Parkinson's and you're in Atlanta, you're very lucky, because Atlanta has great things to help people with Parkinson's. Eventually, I went to the VA. As I said, I met Dr. Hackney and signed up for that tango class, and it was at the VA where the class was, and somehow I put it together, and some people in the class said, "Jerry, you should get your benefits reinstated. You're a veteran. You can take advantage of all this." And I said, "Really?" I said, "Wow." I said, I never really would have thought to do that had it not been for those circumstances for me. So that's what I did. The regional office is right there attached to the hospital here in Atlanta. I, applied for benefits. I'm a veteran. I'm honorably discharged. I'm able and entitled to those benefits. So now I've got all my care is at the VA, and lucky for me and everyone else, a lot of the staff, including Dr. Hackney, that works at Emory, is also working at the VA hospital. So they do double time. You get the benefit of both institutions, is what I'm saying. But the VA has been the answer for me. It's all covered, and I'm so lucky, to have that available to me, and other veterans have it too. So take advantage of it.
well, one of the other resources that you've also mentioned to me was the Parkinson's Foundation. And so can you tell those who are listening now or who may listen to this later a little bit about the foundation itself and the kinds of resources that are available there?
Yeah, for sure. Through Dr. Hackney, I was trained to be an advocate and a uh, participant in the clinical research. You want to know about the benefits at the VA for?
No, through the Parkinson's Foundation
Oh, the
itself.
foundation, right?
Mhm, mhm.
So anyway, one thing led to another. I decided to be a volunteer for the foundation. I became an ambassador. So they have an extensive library of resources with research publications, and they're connected to the medical community. They're they're an amazing place to get information and knowledge and research, and the best treatment for Parkinson's. So as far as learning about the disease, there's no better resource than that foundation. So Parkinson's.org is the place to go. There's a library full of information. There's support groups. I go to a support group once a month. There's support groups all over Atlanta. The Georgia chapter is a very strong organization, and there's lots of resources through that chapter. There's events that happen. Moving Day Atlanta. There's Revolution. There's classes. You can go to Tai Chi. You can go to tango. You can do singing for Parkinson's, ping pong for Parkinson's, bicycling, swimming, you name it. The YMCA's are affiliated with the Parkinson's Foundation. I mean, they do a lot for people who have Parkinson's. So yeah, I'm able to help other people with, by being a patient myself and an advocate and an ambassador. So very valuable resource for people.
Thank you. Dr. Hackney, I think a last question for you. With the work that you've done in regard to movement disorders, et cetera, what's sort of the latest updates or findings around Parkinson's disease? Any that research has yielded? Are there any additional types of exercises or nutrition that are being found to be more helpful for folks or patients with Parkinson's disease?
Thank you. Yeah, I think, well, on the pharmaceutical industry is always trying to improve pharmacological regimens so that it can address issues like off time, feeling like your meds aren't working that well. So nutrition wise, there's more research about that for sure. And I think that we don't have anything very conclusive. I do think you need to eat a healthy diet, just like everyone else. It's very important to eat your vegetables and whole grains and try to cut down on processed foods. There's some information about protein intake and as it relates to taking your medications. If you take a big proteinaceous meal right when you've taken your levodopa, that will sometimes interfere. The protein will interfere with the absorption of the levodopa and your drugs won't work as well. So these things are all very important. You want to look into that and make sure that you're, have a very healthy diet, but you can't eat your way out of Parkinson's just yet. But you can certainly do the things to make yourself as healthy as possible. I do want to talk to you about for those of you who haven't been diagnosed just yet, but you think you might have Parkinson's, there is a national clinical trial at stage 3 clinical trial. And it's, I think 26 sites in the nation, plus 2 in Canada. And it's called SPARKS-3. And if you haven't started levodopa therapy or any of those other ones that precede levodopa, then you may be eligible to join the study and you would participate in exercise several times a week. And if you had, but the thing about it is once you join a study, you can always drop out of a study. And if you have to go on meds, you can. But we want to see if aerobic exercise in particular actually slows down neurodegeneration. It has been shown to be the case in animals, and we want to show it in humans. And we have initial evidence suggesting that aerobic exercise in particular can slow down neurodegeneration, which would be huge in Parkinson's disease. So there's very, 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 very good reason for everyone to do their aerobic exercise. Also do some resistance training a couple of times a week, especially with aging. It's very important. Muscle mass tends to go down. There's a bit of atrophy happening, and you want to make sure you keep your muscles as strong and as fit as possible. Also do balance training several days a week, and that can be Tai Chi, that can be maybe a dance class, that could be martial arts, Kung Fu, I don't know, all sorts of things, whatever makes you happy. I know pickleball is becoming very popular, especially, and do something that gets you on your feet, moving, hold on to whatever functional abilities you have now, and really remember that exercise can be sort of like health insurance because it's going to keep you healthier and away from the doctor's office a bit more. So that's what I recommend. If anybody's interested in some of the studies, feel free to email me at mehackn@emory.edu. Again, mehackn@emory.edu, and I'd be happy, very happy to share the studies that we have or put you in contact with people that can get you enrolled in some of our studies.
Yes, and I would also ask you if you'd send that to me, then we can put it up on the site.
Sure,
With
it's
the,
just my email address.
okay, yeah, we'll
Oh,
do that.
and if you can advertise any of your studies, we can certainly send you some flyers. I'll have some
Okay.
of my coordinators send them to you.
Perfect, perfect.
Thank you. Okay.
One other question for you. You mentioned before that Parkinson's wasn't necessarily a very easy diagnosis to make, and that there are other, obviously, movement disorders. And while we're talking about Parkinson's specifically today, just sort of touch on what some of these other movement disorders might be that could be somewhat confusing or what have you, in terms of thinking about a diagnosis of Parkinson's.
Sure. So they have long fancy names like cortical basal degeneration and parasupranuclear palsy and multiple system atrophy. And these conditions look a lot like Parkinson's, but they're not. And there's a couple of things that, distinguish them. When you have Parkinson's, you have unilateral or just one side onset. It won't be on both sides. And some of those conditions affect both sides. The other thing is you need to respond to levodopa treatment. That's a great way to see if you have Parkinson's. If you respond to levodopa treatment, that levodopa therapy, that means you likely have Parkinson's as well. You have to have the 2 of the 3 cardinal signs or 3 of the 4 if you think about it in the other way. And so that's the other thing, and that's how you make these diagnoses. There's also something called the DAT scan, where you go in and you get imaged essentially for the amount of dopamine transporter that remains in your brain. And that's pretty effective. Some folks would say you could also do an MRI, like the neuromelanin MRI is one way that you might be able to also detect if someone has Parkinson's by noting the amount of iron accumulation and the amount of losing melanin in the brain. So in the areas that produce Parkinson's. So there's a lot of different ways to do it, but the DAT scan and those other things, those are typically a bit more expensive. And so a lot of people get it from just that, the behavioral symptoms and whether or not they do respond to levodopa treatment. But it is very difficult. And you just have to work with your care team to figure out these things. But a movement disorder specialist will be able to give you a pretty, a diagnosis with a high degree of accuracy.
Thank you. Well, we're coming to the close of the hour here. And so I will ask you, Jerry, is there anything else that you might want to ensure that people learn about or hear about from you about Parkinson's, either through your experience or things that you might just want to share with them?
Well, I would welcome anyone on the call to get in touch with me as well. And I'll make sure to provide that contact information, Dr. Lewis. And I can be reached through the Parkinson's Foundation. And the big message for me is, take ownership and advocate for yourself, manage your condition, and stay positive. And don't sink into some hopeless depression. That's not going to be helpful in any way. So, there's a lot to live for, and that's how I feel. So I'm okay with whatever I got.
Thank you. Dr. Hackney, you have anything you want to leave everyone with here before we close?
I echo everything that Jerry says. Get out there, get the support you need. There are a lot of resources. Take advantage of them. Work with your care team. Start exercise and eat well.
Perfect, perfect. Well, thank you both for your time today and for your willingness to share this information with those who will listen to this later on, as well as those who dialed in or who are listening to us on Facebook. We thank you for coming and hearing what was being said here, and we hope that you'll take this and share it with others who may be having some trouble with movement disorders, may have already had the diagnosis of Parkinson's, and may not be in the same space as our guest today, Jerry, in terms of being in a positive mindset. And so if you know of anyone who does need help in this area, please don't hesitate to contact us, the foundation. We'll have Jerry's contact information there. We'll also have those flyers available with the research trial information that Dr. Hackney mentioned. So in any way that you think we might be of service or help to you or to someone you know who has this problem, please don't hesitate to get in touch with us. Again, this is Dr. Lewis, Chair, founder of the Veterans Health and Wellness Foundation. You can find us online at myvhwf.org. And feel free to give us a call or send us an email if we can be of service to you. Thank you again to my guests, and thank you again to those who attended and who will listen to this taping later on. Wishing you all a very good afternoon. Thank you.